Hi, everyone. Welcome to the latest episode of the Power Within podcast. And in this episode, I have a fantastic guest. His name is Garry Coles. Garry is a UK-based hypnotherapist that specializes in hypno oncology. So we're going to find all about that today and the work that Garry does. You know, Garry spoke at the Irish Hypnotherapy Conference earlier on this year, so some of you may have seen him at that and may be familiar with the work that he does, but I can't wait to get into all of that great stuff here today with Garry. Garry, it's great to have you on the podcast. Thanks very much for coming on.
Oh, thank you very much for inviting me. It's a pleasure.
You're very welcome. Now, I have to admit that hypnagogy, folks, is not something I know a huge amount about. So Garry, can you let us know a little bit about your story and your journey, first of all, of how you got into this line of work and this
Yeah,
kind of special focus on hypno-oncology?
yeah, absolutely. Obviously, as you know, my name's Garry Coles. I'll give you sort of my background initially before I got into it. I've been a full-time hypnotherapist for coming up for 20 years. I was one of the first people in the UK to get a master's degree in clinical hypnosis. I have a Master of Science degree in clinical hypnosis. That was a research master's, and it was awarded for a pioneering piece of research that I did. And that was it. I did research into pre-surgical hypnosis and the effects that had on recovery quality in breast cancer operations. And I was able to demonstrate that it did and how and why. And interestingly, on that, now the Royal College of Anaesthetists in the UK now recommend pre-surgical hypnosis. Now they don't call it that; they call it pre-surgical relaxation. But actually, they've got recordings, and it is pre-surgical hypnosis. So we
Right.
are getting there.
Yeah, yeah.
Um, I practice 1 day a
Excellent.
week in an oncology unit at a large cancer hospital. I've been doing that for over 18 years, so I've worked with about 2,500 cancer patients. So obviously I've done
Wow.
research in that area. Um, because I've worked with that many patients, I know what works, what doesn't work. I've designed techniques and approaches. The hospital has sent me on lots of cancer courses. So I've got a lot of knowledge on that. And I must admit, I didn't realize quite how much knowledge I had on that until after I'd done my master's degree. And it was sort of quite funny to get where I am. I've got 5 practices in the southeast of the UK and in London. And I work with clients all around the world with Zoom. Um, Also, just as a slightly aside, although hypnotherapy isn't regulated, in the UK we do have the Complementary Natural Healthcare Council, which was set up by the Department of Health initially, and I'm actually on the profession-specific board for them. So I'm one of the team of 3 that puts together the national curriculum for training for hypnotherapy in the UK,
Very good.
after their ethics, and also
Right.
occasionally, rather sadly, you have to sit on boards for malpractice cases and things like that, which is interesting, but so it's something else. So that's sort of me, if you like. It's sort of the cancer journey, or well, hypno-oncology to me is hypnotic interventions for the cancer journey. That's what it is. The big thing is we do not treat cancer. That I want to put out there very, very quickly.
Right.
Because in America, I've seen lots of dodgy websites saying, oh, we can use hypnosis to cure cancer. In the UK, we have the 1939 Cancer Act. It's actually illegal to say that you can treat, remedy, cure, or offer advice about treatment and so on for cancer patients unless you're medically qualified. So you do have to
Right.
be
Okay.
careful what you do within that area.
Sure.
But to me, I say it's hypnotic interventions for the cancer journey. So we're going to help people through that journey. Now, it's a big area to get into. A lot of people don't realize the statistics are quite worrying. And the statistics are that in the Western world, 1 in 2 people born since 1960 will be affected by cancer at some point in their life. 1 in 7 women will get breast cancer, 1 in 8 men will get prostate cancer. Bowel cancer affects 1 in 15 men and 1 in 18 women. Lung cancer is 1 in 13 men and 1 in 15 women. And the interesting thing for therapists, particularly hypnotherapists, is that SAGE research shows that 40% of cancer sufferers will seek out complementary therapies. So, if you like, that's 20% of the population will seek out therapies such as hypnotherapy. And in
Right.
some countries like Australia, it's as many as 70% of sufferers will seek it out. So that's 35% of the population. So that's an awful lot of people that could be looking for our help.
Yeah.
So is another reason that I'm in that area. Um, the way I got into it was a little bit of an accident, I guess. I have had experience in my family with cancer. I looked after my mother. Rather sadly, she had non-Hodgkin's lymphoma, and she died in her early 50s. And that was all the way through from sort of the first day of I don't feel particularly well, I'll go to the doctors, right up to the awful day where there's nothing else we can do. Sort of being with her at the end. I also looked after my grandfather who had esophageal cancer, but he died at 94, so we can't really complain on that side particularly because he still had a good life, even though he did go through the cancer journey.
Mhm.
Um, so that I sort of fell into it by accident. I started being a hypnotherapist, and it's gone full circle really. Because I started being a hypnotherapist, and even that was a bit of an accident how how I come to get into the industry. Prior to that, I was an IT consultant in the oil industry with a maths and computer science background.
Right.
Um, but I got into hypnotherapy, and not long after I qualified, I had a phone call from the hospital, and saying, "Oh, we used to have a hypnotherapist here. It's really good working with cancer patients. They've gone. Could you donate some time to us? It'd be really great." And at that point, I was a little bit mercenary. I just qualified, and I thought, yeah, I need experience now. So if I go to the hospital, they can offer me up to 8 patients a day. So that is going to get me great experience. So I'll be there. I'll go there for 2 or 3 weeks and get lots of experience, and then disappear. 19 years later, I'm still there. So that didn't quite work out as planned. I know I'm now only there for 1 day a week, seeing patients. But it went full circle in a nice way, because the hospital sent me on lots of cancer courses. So I learned quite a lot about it. When I did my master's degree and I did my research got out, and I started getting email inquiries, or you seem a bit of an expert. Can you give me some advice in this area? Um, then I was asked to do a couple of podcast interviews, so I got more emails. Then I was invited to the first UK hypnosis convention in London, which I believe was in 2017, and I've spoken every year since then.
Right.
And at that point, a few people suggested to me, "Well, you're a bit of an expert. You ought to put a course together to teach doctors and psychologists and hypnotherapists how to work with cancer patients." And at that point, I thought, well, nobody's going to be interested. But then I was invited to go to more and more conferences. I regularly do Hypnothoughts in the USA, in Las Vegas, which I'm doing next month, and the Mid America in Chicago. And it then became obvious that there was a market for it. So I've done a few things. I put a script book for hypnotherapists together. I'm currently writing an academic book. I put a training course together, which I do online and live. Also, I do monthly mentoring. And that started to take off. So I ended up teaching people in the UK. Then I've done people online to Australia and New Zealand. I've done doctors in Belgium. I was invited to go and teach psychologists in Bahrain. So it seems to have gone global now.
Brilliant.
Go all around
Fantastic,
the
isn't
world
it?
and teach people. I go all around the world and talk to people. So yeah, it just took on a life of its own, really, I guess.
Sure. Brilliant. And in terms of the work that you offer and the help that you give people, would it be over a course of a number of sessions or programs?
Well, that's the interesting thing about working with cancer patients, hypno-oncology. It falls very much into two sort of distinct camps. And we'll start off with what we can work with, and why. I mean, the first thing is, which I will make a big note again of, we do not treat cancer. We work with the cancer journey. We do not treat cancer itself.
Sure.
So we're not regression to cause, or, and things like that. And one of the worrying things is that people undergoing the cancer journey are very desperate. They will throw
Yeah.
money anything that they think might give them a lifeline. And there's some more worrying statistics. This is from America, not over here. The American Society of Clinical Oncology did a survey of 4,000 adults. 25% of those had cancer and were going through the journey. And out of their survey, 40% of them agreed that cancer could be cured by oxygen, diet, and herbs, and nothing else. Um, Half of them thought that cancer could be cured by complementary therapies alone. Now, the worrying thing about that is that if you just use alternative therapies and no mainstream therapy, that doubles the mortality rate. So the patient has got twice as much chance of dying through it. If that's in early stage cancer, that rises to 6 times. So that's rather worrying. They've got 6 times higher chances of dying if they don't have mainstream treatment and just rely on alternative therapies. So we have to be
Right.
careful.
Okay.
We do not treat cancer, and we can do experimental work as long as it's for the patient's well-being, psychological well-being. Uh, so to go along that lines, the things that I work with, when I say it's for the cancer journey, I will work with if you like, the diagnosis, so the psychological fallout from that, the fear, the panic, the worry about the future and the treatment,
Sure.
and so on.
Sure.
Then we will perhaps work with fears and phobias. They might be frightened of going into scanners, having needles, that type of thing. A big one is actually for head and neck cancers is claustrophobia, because they have to have a mask cast to their face and they're bolted down to the treatment table for radiotherapy. That freaks a lot of people out.
Sure.
So we deal with that. My area of research was pre and post surgery hypnosis, which does appear to give a faster recovery quality psychologically. It also seems to give a better physical recovery quality. And one of the things that we noticed is that the people that underwent pre-surgical hypnosis, a week after surgery, they were perceiving that they were in less pain than the group that didn't have hypnosis. And when we
Okay.
drilled down, we found that not only were they perceiving less pain, they were actually taking less pain medication. So it appeared to make the medication more effective. So there was a lot of good things on that side. So
Sure.
I do a lot of work with pre and post surgery. The biggest area I work with is probably side effects of treatment. So things like anticipatory nausea, for example, with chemotherapy is probably the most common. Sleep issues, thing called dysgeusia, which is smell and taste issues with food and drink. Those are pretty common areas that I would work with. Another area is pain control. Hypnotherapy is the biggest studied complementary therapy for pain control and very effective.
Sure.
Uh, so we use a lot
Yeah.
for that. Um, we also sometimes look at it's a wake up call for other things going on in the patient's life. Having had a cancer scare, they might want to remedy something else that's wrong in their life, a fear or a phobia or an addiction or something like that. So we work on that. I work on palliative care if required, and also post cancer journey, if you like, once they're given the all clear, with which happens thankfully more and more common nowadays. We might sort of look at them further down the road. There might be fear of reoccurrence is quite a common one, or sometimes there might be other life enhancing things that we can help them with moving forward. So we look at the whole journey, if you like, going through it. There are some experimental areas we can work with, although we can't work with the cancer as such. Some people like to have guided visualization of imagining that they're dealing with the cancer. So we would do things like
Sure.
that. Again, as long as it's for psychological well-being, we might do guided visualizations as perhaps seeing the cancer as an overlay that the patient can modify themselves. Pac-Man is a popular one for people of a certain age. You imagine a Pac-Man, as in the game, going through and gobbling up the cancer cells.
Yeah.
Uh, that is quite a popular one. So we can do
Very
things like
good.
that. And another experimental area, which perhaps we'll talk about another time, it's another area I do a whole lecture on, is an area called psychoneuroimmunology, PNI for short. And it's the study of how feelings and emotions can affect the immune system. And there is a lot of evidence that shows that it does and can. Now, if we take that full circle, if we can prove that the immune system can be modified by feelings and emotions, talking therapies can modify feelings and emotions,
Yeah.
or assist with them. So if
Right.
we take that full circle, we can theoretically modify the immune system using things like hypnotherapy. And there is a lot of research out there. It was started by a guy called Dr. Robert Ada from the States in the 70s. And there's a lot of interesting evidence and more being formed out there that shows that that is in fact the case. So I think that could have good implications going forward. Um,
Fascinating stuff.
yeah. So going back to your initial question about
Yeah.
is it one session or a course of sessions,
Yeah.
it varies. Um, Quite often, particularly with a diagnosis or something like somebody being fearful of going into a scanner, I might be faced with a patient having a panic attack. So I would do what we call an emergency intervention. I would be called in. There's somebody standing there having a massive panic attack that needs to be under control very, very quickly because they need to have a blood test or go into a scanner or something needs to happen. And if that doesn't happen in that time
Sure.
frame, the next 15
Yeah.
minutes, you're going to lose that slot and they're down the line for a few months. So quite often, yes, you have to do one very instant emergency piece of therapy where you don't have time to introduce yourself, you don't have time to talk about hypnotherapy or take a case history. You're just straight in there doing whatever needs to be done to work with that patient to
Right.
stabilize the way that needs to be done. And that can be a lot of things. It can be submodality techniques is quite a popular one, breathing techniques, tapping techniques,
Yeah.
also, by sort of techniques for looking at different hemispheres and things like that. So there's a lot of things you can do, and really you need to gauge that to the patient that's in front of you. But
Sure.
you
Sure. I'm sure that it helps in terms of their mindset, because being in that situation obviously is going to be challenging, to keep a positive outlook
yeah.
on the scenario. So I know that the work that we do in general will help them, with the end of it, wouldn't it?
Absolutely, yeah. So, so
Yeah.
that's the first thing. Yes, you would be dealing with a lot of people that are having a one-off session, which I would call an emergency intervention. Then you have the others that, yes, you would
Yeah.
do a series with, and that depends on what they want to work with. Quite the first thing I always say with a patient is you need to stabilize the patient. The difference that you tend to have working with cancer patients in hospital, with my private patients, I've spoken to them on the phone or via email. So when they come to see me, I know what they're coming to see me for, and I possibly know a little bit more about the background. With a cancer patient, the first time I see them is when they turn up in my office at the hospital. So I know nothing about that patient up until that point. I don't know
Right.
why they've come to see me, what they want to do, or anything like that. And also in hospital, we're very restricted on time. I get a maximum of 50 minutes, typically 45, because generally they need to find the office in the hospitals, which can be difficult. They might have difficulty parking. I need to file the notes and stuff like that. So in reality, you'll get 40, 45 minutes in hospital. So you have to pile in pretty quick. So session one, I will always do a stabilization technique. I tend to have a technique that will uh, deal in with negative feelings and emotions. It's a pretty good starting point.
Sure.
So it's a dissociative technique for negative emotions, and follow that out with some ego strengthening and that type of thing. That would be a typical first session, as long as it's not one of the emergency interventions that we just mentioned. If it's just somebody that's going to come and see me for, say, a phobia or something like that, or
Sure.
side effects, anticipatory nausea, something like that. We would do a stabilization session, then we would progress on to other sessions, and that would be depending on what they were looking for. If it's fears and phobias, I might do some parts work and as well as suggestion, potentially some regression to cause if it's appropriate, but not always. So you would plan out again what you want to achieve with that particular patient, and map out a way of doing it. Other things that you need to be very aware of, though, working in that environment, is even if you're seeing a patient for a number of sessions, um, the setup is going to be different to a private patient, because generally, if they're coming to see you at the hospital, they won't make a special journey to come and see you at the hospital. They will see you on the day that they're there for other treatment. So they might be coming in to see the oncologist. They might be coming in to have a scan. They might be coming in to have chemotherapy. So you do need to take into account that they've either had treatment or a consultation, in which case they might be very, very tired, very
Yeah.
emotional, or it might be the other way around, that they're coming in to have some treatment or a scan or a consultation, in which case they might be a bit fearful and panicky anyway. So you do need to take those differences into account in that environment that you wouldn't necessarily get in a normal sort of clinical environment.
Sure. Right. But it's fascinating stuff, and it sounds like you've been, like that the medical establishment is getting more and more open to this type of work, like hypno oncology, and like how do you view that in terms of like its acceptance in that field?
It's very mixed. It's very, very mixed. Certainly, give example in my hospital, two really good things is one. Recently I was asked again to go and talk to the cancer nurses and give some demonstrations, and they're very for it. They refer a lot of patients to me and other complementary therapies, but particularly for hypnotherapy, because they can see the power of it. When I
Yeah.
did my research for my master's at the hospital, again, I all my people that I worked with were at the hospital, and again the cancer nurses were recruiting people for me because they could see the benefits. The greatest thing that I thought I had at the hospital was I had to go through as you can imagine, I had to go through lots of ethics for it. A lot of people said I was completely mad going for that sort of line of research.
Yeah,
I had to go
right.
through NHS, the National Health Service ethics. I had to go through university ethics, and they panicked like crazy because I was on the first cohort and they were expecting people to do research into smoking and weight loss. And when I went in there and said I want to work with cancer patients, they sort of absolutely panicked.
Jeez.
I had the same thing when
Yeah,
I had to go to the Hospital Research and Development Ethics Committee. They were very panicky about it as well. And
right.
the final thing that I had to do was the teaching surgeon, and I went to the teaching surgeon. They said, right, it's going to be her call, yes or no. She wants to interview you, and it's going to be yes or no. And if it's no, that's it. And I went in, and she gave the attitude to me of, I'm a famous teaching surgeon. Why are you wasting my time? Sort of attitude. And I
Right.
realized looking back, she was testing me that I wasn't wasting her time, that I was going to provide robust, valid research. And at the end of it, she said, "Yeah, okay, we'll do this." And what was absolutely fantastic were about eight months into my research. I did it all myself. I did the hypnosis myself before the surgery and so on. And I remember one Friday morning, because most of the breast cancer operations were done on a Friday. I remember one Friday morning, the teaching surgeon coming up to me and saying, well, we're starting to see the results now of your research, and we're starting to see which patients it works best with. If you'd like me to change my elective list around to accommodate you, let me know. And I thought
Brilliant.
that's a win. If we got the surgeon moving
Definitely a win.
around,
That's progression for you.
that's progression. But on the other side of things, it's not so good. It is becoming more accepted, but on what they derogatorily call us lay hypnotherapists. Like, for example, the Royal College of
Yeah.
Anaesthetists, they now advocate pre-surgical hypnosis. Um, they have recordings on their website for pre-surgical hypnosis, except that they call it pre-surgical relaxation. There's no mention of hypnosis, apart from the fact that they were recorded by I think it's I can't think of the name of them, the UK, it's Medical and Academic Hypnosis, or the Royal Society for
Right.
Medical and Academic Hypnosis. Now the problem I have with them is they are very much against what they call lay hypnotherapists. On their website will say, yes, hypnotherapy is great, but you should only go to somebody who's medically qualified. So your doctor must recommend somebody to you, and they should be a doctor or a psychologist that you go to. So they're not helping us.
Yeah.
And I actually met them, or I've met them a few times because we've talked on the same conventions. But I saw them at a seminar at the Royal Medicine, and uh, and one of the things that was good is that they were talking about analgesia and anesthesia with hypnosis, and it was very interesting, and they were very enthusiastic about it all. But to my mind, the techniques that they were utilizing were rather old-fashioned. I thought they looked like the sort of techniques that we'd be using 30 or 40 years ago, and things have moved on communication and language-wise since then. And I actually spoke to them, and I said, "Look, I said, who teaches your techniques?" Because I said it's really brilliant. It's fantastic. You're enthused by it. But I said I think some of your techniques are a little bit dated. There are better ways of doing it now.
Yeah.
And they said, oh, it's Doctor Such and Such. And so I went to see Doctor, and he's been teaching us for the last 30 years. And then I saw Doctor Such and Such. Where did you learn? Oh, well, the guy that was here before me, a member of this Royal
Right.
Society.
Yeah. Yeah.
So it's been passed down from generation to generation.
Yeah. Yeah. So it's
And
all outdated kind of
Yeah,
approaches that we're
yeah.
using.
And I said to them, I said, well, I said, with all respect, I said, you're all doctors and surgeons and psychologists and so on. But I said, but I've got a master's degree in clinical hypnosis. I've researched it quite extensively. I lecture all around the world to doctors and so on. I said, I could come in and talk to you and give you some tips on how you could modify what you're doing. Or I said, even, come and assist you with teaching. And I got an absolute blunt no. Oh, no, 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 you can't possibly do that. You've got a master's degree in clinical hypnosis, but you're not a doctor. You're not a doctor. You're not a psychologist. You
Yeah.
can't possibly come and talk to our organisation. In fact,
Yeah.
they wouldn't even let me join the organisation, let alone talk to them. They said, but you're a lay hypnotherapist. No, you're not a doctor or a psychologist. So, we're just very dismissive.
Yeah.
And I come across them at other conferences, and that is their attitude is, oh, and unless you're a doctor or a psychologist or a dentist, you're a lay hypnotherapist, and the public shouldn't go and see you. So although it is becoming more accepted, it isn't by certain fraternities. They're still trying to keep it a closed shop.
That's very frustrating, isn't
Yeah,
it? To have that kind of, I suppose, nearly almost condescending
yeah,
kind of
absolutely.
attitude towards the work that you offer.
Yeah, well, I have one of my colleagues actually. She's a doctor, not a medical doctor, but she's a doctor, and she was out recently at a conference in Poland. And again, they had a similar organisation out there talking about lay hypnotherapists, who they were referring to as amateur hypnotherapists, and are tied up doing stage things and all sorts of other things, bringing the industry into disrepute. And they seem to have no real idea of what we actually do. But again, they were doctors and thought, oh, well, we do it our way and nobody else should get involved.
Yeah, sure, sure. I'm so interested in this topic, and in terms of like the clients that come to see you that you help, is it something where, like, I'm sure in your intake form, or when you're assessing them coming in, that you assess their lifestyle choices, because, like, do you have a view on how they have reached, I suppose, that point in their life where, like, they have cancer, and and the choices that they made in their life, like whether it be smoking, for example, if it's lung cancer, would it be something that you would obviously factor in to help them change those lifestyle choices?
Interestingly enough, generally no, is the thing on that front.
Right. Okay.
Because generally, because again, time is short, and as far as the intake form is concerned, it's very minimal at the hospital. It's more medical than whereas where I'm seeing a private client, I will look at people's lifestyles and all sorts
Yeah.
of things that
Sure.
I have. The hospital intake form is very, very basic. It's based. There's nothing on lifestyle. It's all based on what the diagnosis is for the cancer.
Right. Okay.
That's the only thing I get. I don't get a lot of time to do anything else, as far as that's concerned. And generally, they're coming to me to deal with a particular aspect of their journey. So they might have got lung cancer through smoking, for example, but they're there because they want some help with an aspect of the journey with lung cancer, rather than how they got there. Interestingly enough, quit smoking is one of the few things that I refuse to do in hospital as well. Um,
Right. Why is
uh,
that? What's the reason
uh,
for that?
the reason is that generally I only get about 45 minutes. With quit smoking, I take an hour and a half to 2 hours. I also give backup materials and also other things. But in my experience, if somebody is not shocked enough by having a cancer diagnosis or being told that you're not going to be operated on unless you give up smoking, um, giving them a free session is not going to help,
No.
because if they're
No.
not motivated
Yeah.
already, and there is a lot of statistics that show that you really need to get a buy-in from the smoker, and the usual way of doing that is by hitting them in the pocket. There's been research out there that shows that the less money you charge for a quit smoking session, the less chances of success will
Sure.
happen. Uh,
Absolutely.
and I found in the very first days, I did do a couple of quit smoking sessions in hospital, and they failed dismally, because I couldn't do them in one session. I had to divide it over into 3 sessions. They were free, but through the hospital. And I had a couple of patients that did one session and didn't turn up for the second one. Oh no, I didn't like it, it was rubbish, and all the rest of it. And I thought, well, that's going to harm my reputation, so I'm not doing it. So no, so that's one of the things that I don't do. Um,
Sure, sure.
and
And
so,
even like
so
if it's other kind of lifestyle kind of choices, if it's kind of other, depending on, I suppose, the type of cancer,
yeah,
like it could be, I mean, if somebody is like overweight, or like
yeah.
has a poor diet and things like that, is that thing so you wouldn't take into try and change that necessarily?
Again, if that's what they want, but typically, the only time I would tend to do something for weight loss, for example, was if I've got a patient that needs surgery and the surgeon will not do it unless they lose weight. So I will work with them on that.
Right. Okay.
Typically not, because generally, even if I've got a patient that's perhaps had a bad diet and that's why they've got cancer, generally they're coming to me at that point about the fear of going through the journey, or they want treatment for the side effects, or panic and all sorts of other things. So really, the sort of their lifestyle is probably the least thing they're worried about at that point in time, because they're going through the cancer journey.
Sure,
That's the thing they're concentrating on and worried about, not how they got there.
sure, sure. I get you.
Yeah. And
What,
also, and
what's the
also,
biggest reward? Sorry to cut across you there.
yeah,
What's the biggest rewards in terms of the work that you do? Like, do you? I'm sure you get some fantastic feedback in the results of the work.
yeah, I mean,
Yeah,
just knowing you can make a difference, and give people an easier journey, if you like. When I did my research, I got lots of unsolicited letters from the people that I worked with, saying that they didn't think they'd have got through the surgery without my help, and they were amazed at how easy it was, which they put down to my work, the work that I did with them, and that type of thing. So I mean, that's very rewarding, seeing that you can go through it. And just seeing, I mean, it's one of the
that's
things that you don't see a huge amount of people the other side. It's that they come in, they see me as part of their journey, and that's the last I hear of them.
yeah,
Help them, particularly with the fears and phobias, if they can go into the scanner, or if they can have the mask fitted, which they couldn't have done previously, you've done your job well, and that you've helped, because they can now do the treatment that they need that might save their life. So that's all very rewarding.
sure.
But you do get some case histories that can be really rewarding. I think that probably the nicest story that I've had was a cancer patient I worked with a few years back, and the lady was in her late 20s. She had a very active lifestyle. She was into parachuting and doing all sorts of things like that. She was diagnosed with colon cancer, but they said that they didn't think it was too bad. It would just be a basic keyhole surgery sort of intervention, and then everything should be fine. She'd heal and carry on her lifestyle. They opened her up and found that a lot of things hadn't seemed to have come up on the scans, and that it actually spread significantly. They took the decision at that point to do very serious surgery. They had removed her entire colon. They gave her a colostomy. There was other things they took out. They had to break all her ribs on one side to get everything. Uh,
Wow,
then she came round, obviously was in
scary.
extreme shock, in extreme pain, because all this had happened that she wasn't expecting. Um, she was in a lot of pain, couldn't sleep, and so on. They said because it had spread significantly, she had to have very heavy dosages of chemotherapy. She was one of the people that reacted badly towards it, and she died a couple of times and had to be resuscitated.
Mm.
And that's the first time I saw her. Was just after she'd been resuscitated for the final time. Uh, she was in the hospital bed. I don't normally see too many people actually in the wards. Normally they come to me, but she was in such a bad state. She couldn't sleep. She was in so much pain, incredible shock. So I started doing some work with her, and we worked a little bit on the pain, and then we worked a little bit on the psychological side, and then bits on sleep. And so we started making some inroads, and then it got to the stage that she was still a hospital patient, but she'd come and see me in my office rather than at the bed. So we worked on other things with that. Then she healed enough that she left hospital, and she was still coming and seeing me as an outpatient. And we were still working on all sorts of things, from, the psychological fallout of the changes in her life, and, to the sleep issues, the pain issues, healing issues, all sorts of other things. And then I didn't see her for a couple of years. The last time I saw her, and this was a few years back, the last time I saw her, she came to see me as a private patient. She wanted sports performance. She wanted me to assist her with improving her triathlon performances.
Wow,
So that
really amazing.
really great. Yeah.
Wow. I see you
Yeah.
were shocked with that. Is this the same person?
Yeah, yeah. But I thought that's very encouraging. You can see that they're at the lowest low, died a couple of times, taking the colon out, and all the ribs broken, to, yeah, wanting to improve triathlon performances. So I think it's great.
That's a fantastic result, and it's inspiring to hear that story, and I'm sure there's many more like it. And
Yeah, yeah. You
we
did very
were
well.
speaking before we came on air there, that you did speak at the Irish Hypnotherapy conference there a couple of months ago,
Yeah.
and you're a regular speaker at the conferences, hypnotherapy conferences and events around the world, and that you're heading off to Las Vegas to Hypnothoughts
Yeah,
shortly,
that's in fact a month tomorrow. I
the
shall be
one tomorrow.
States. Yeah, that'll be
Yes,
the seventh time I've been invited to speak in Vegas. So yeah.
Fantastic. So the response must be very good then. I mean, if you know you're invited back to speak at all of these events, that
Yeah, it's encouraging. Yeah, I mean,
yeah,
this year I've done a couple of online ones. I've done a world one. I've done an Alman one. I've done an Australian one. I was live at the Irish one.
brilliant.
I've got Vegas that I'm doing for seventh time. I'm doing the Mid America in October in Chicago.
Right.
I'm doing the UK one in London in November. I believe I'm back at the Irish one, hopefully next April. I believe I'm doing one in Denmark in March, possibly one in Florida in February. So yeah, there seems to be a lot of demand for it. So that's good. I keep the word out there.
Fantastic. And is there many hypnotherapists that are like focused in on hypno-oncology as their area of speciality?
It's getting more common. It's getting more common because, as I mentioned at the beginning, if one in two people are going to experience it, and 40% of those are going to want complementary therapists, the market, if you want to call it a market, there's 20% of the population are seeking services, and there aren't enough hypnotherapists, I don't think, with the experience and the knowledge to take on that market, which is where I want to get it out there more, and
Sure.
also. One of the reasons that I put my training together initially was really it came to me through hypnotherapists that because of the area or the background that I had, I got contacted by hypnotherapists who suddenly had a loved one in their family diagnosed with cancer. It might have been their other half or, a parent or a child. And although they were very experienced and very well qualified, they would suddenly fall apart. They didn't know what to do. And what can I do? What can I do? And that was when I thought, well, yeah, perhaps they do need advice. Perhaps there is, techniques that they ought to be able to know, and the background to what the patient is going through would help them. And that's when I got sort of the training together, if you like. And since then, yeah, it's improved well. I think I've trained around in the region of about 600 practitioners myself
Right. Very good.
personally. Many others have bought my script books and so on and so forth. And I've got others that I haven't necessarily trained with, but are part of my mentoring group that I do each month. So it is getting more. It is getting out there more and more, which is good. And I'm just hoping we'll
Brilliant.
get even more involved. And
Fantastic. Fantastic.
hospitals tend to be more open to it. The patients
Yeah.
themselves, there was about 40% going after it, but I think people, particularly in the Western world, are now looking for a more holistic approach to illness. And I think although they're going to go down the mainstream cancer route, they want to look at it as a holistic treatment. So they want other things such as ourselves as part of that treatment. And I think even the health services are going slightly along that route now of looking at overall wellness and holistic approaches, which is where we come in. I
Brilliant.
think the biggest problem we have is the people referring to us as lay hypnotherapists, the doctors and so
Yeah.
on. And
That's
I
it.
think the only way round that, I think, is we've got to ensure that our training is robust. Um, there is an argument, should we be legislated? Should we have a governing body that's recognized? That's a whole different debate. But I think the two things is we should ensure that our training is robust, not just a weekend course or something cheap online. And uh,
Sure.
and I
Sure.
think we need more and more research, as in the way of the research side. And there is a lot of research out there for hypnosis in medical, in medical uses and cancer uses. And
Sure.
I
Sure.
think to
It's
highlight that more and get it out there.
Sure. It's part of the challenge that we all have. And I know, like, I mean, I've been doing a lot of work here to, I suppose, naturalize the word hypnosis, because the word hypnosis itself, of course, unfortunately can be a barrier for a lot of people to take that step to come to see us, can be a little bit scary.
Yeah,
And, it's a lot, I do a lot of work here to get the message out that, look, put that word aside for a moment, because it is only a word. That
yeah,
we help people, like in my case here, in my practice, I help people connect with their subconscious minds to make transformational life changes, and feel better about themselves, and lead a healthier and happier life. you know, because there is progress, I feel, being made
Mm.
in terms of the acceptance of hypnosis, that word.
Yeah,
Because, like, I mean, I've been doing and giving public information talks down here in the southeast of Ireland. I've given over 50 public information talks at health fairs and, you know, to retirement groups and, you know,
yeah,
you name it.
yeah,
But you know, there's work. I think there's progress being made, but I think there's more work to do for us hypnotherapists to continue, you know, getting the acceptance of, you know, getting it more accepted. So, you know, it's like for me, it's important to make sure that, um, you know, the work that we do is as accessible to as many people, you know, as possible.
yeah. Yeah, and you're right. I mean, it is this word hypnosis that seems to be causing the problem. It is particularly irritating when people like the Royal College of Anaesthetists sort of basically do hypnosis, but then say, "Oh, this is guided visualization and relaxation." No, it's
Yeah.
hypnosis.
Yeah, yeah,
Tell them what it really is, and
yeah,
that will get
yeah,
over
yeah,
the fear. You know, if it becomes an everyday word and you know, and something that everybody associates with being really useful, then we won't have that problem with the word anymore.
exactly,
I
exactly.
think at the moment it is like the word cancer. It's emotive to a lot of people. It has
It is.
an incorrect meaning because
It
it's
there's a trigger there for people.
yeah,
Yeah, yeah.
absolutely.
But Gary, listen, it's great. It's been great having you on the podcast, and I've been absolutely fascinated with this discussion and you know, listening to all of the great work that you do and the type of work that you do is fascinating. And you know, it's some, as I said at the start of this podcast to you, it wasn't a subject that I know or I knew a huge amount about. So just one eye on the time there, and you know, I don't want to keep you too much longer. So, have you any words of wisdom you'd like to share with myself and my viewers and my listeners before you say goodbye here today?
Yeah, I would say for hypnotherapists, and I always get asked by particularly hypnotherapists or other therapists, you know, any tips, particularly for new people. I would say communication is very important. See it the patient's way, use their view of the world, be congruent, and use what you have in the environment. But as far as tips, other tips on that, I'd say always have a plan B, C, and D. Whatever happens in the session, you should make the patient think that that was what was meant to happen, even if it goes completely wrong. And then
Yeah,
you move on
that's
to
a good
session.
one.
Then
Yeah,
you go on to B.
yeah,
I always thought confidence was the number one thing that you needed to be a hypnotherapist in this area, but I would now say intent is more important. You have to have the confidence to carry out that intent, but I think the intent is the number one key in whatever you actually do in a process. And the other one that I like, particularly for new hypnotherapists that might be worried that they got the technique wrong, missed a bit, or got scripts based wrong and things like that. There's a lady called Melissa Tears, not to be confused with Marissa Peers, an RTT. There's a
right,
lady
okay.
in New Jersey called Melissa Tears, who's very, very funny. And one of the things that she says, her big tip is says, remember people, we just make this shit up. And I think that's
Exactly, exactly. Is there any tip you would have for, say, if you know, I'm somebody watching this podcast here, and unfortunately, like I have cancer, and I'm thinking, I'm looking at an option, and I'm considering getting in touch with you.
yeah.
Have you any tip that you would recommend in terms for them?
Yeah, obviously they can contact me. As you can see in my background, we have
Yeah,
hypnooncology.com that they can contact me. There's also a list of some of the people that I've trained around the world, if they're, you know, in America and Canada and Australia, if they want somebody more local. I work with clients via Zoom all over the world anyway. And also there's details for people that are hypnotherapists that are interested in this area. There are details of online training, USB card training, script books, and mentoring and all that sort of stuff.
sure, sure. And would you, obviously you would encourage them to approach it with the right mindset to get the, you know, the value and the benefits
Absolutely,
from
absolutely,
it?
and I think you know, I think this is an area. that we need more and more hypnotherapists. As I said, we're looking at 20% of the population moving up to 35% in some countries that are going to be seeking out this type of therapy. So
Excellent,
we
excellent.
need to be there to provide it. You know,
Great stuff.
if you want to do it as a charity, you know, that's another side of it. People have different reasons for doing it. Some people want to make a career out of it. That's their number one niche. Some people want to do it as a charity. You know, it's a combination. I do it as a combination. I always do 3 free sessions a week for cancer patients, just to give something back. But other than that,
Really
yes,
well
it's
done.
one of my specialisms. So
Great stuff. Well, Gary, you're a gentleman and you do great work. And look, thanks a million for
thank you.
taking the time to come on the Power Within podcast. I really appreciate it.
Thank you. And I look forward to catching up with you in person, hopefully next year or somewhere else.
Yeah, so best of luck with all of the speaking events, and you know, be safe traveling over to Vegas at Hypnothoughts,
Yeah.
and most importantly, enjoy
Yeah.
spreading the
Excellent.
message and spreading the word. So that's great. Thanks very much, Gary. So,
Thank you.
folks, it's that time again to bring another episode of the podcast to a conclusion. You know, if you're passionate about mindset, about mental health, if you're a hypnotherapist that, you know, wants to improve and is looking for new ideas, and, you know, if you're passionate about the work that you do, this is the podcast for you. Make sure you like, subscribe, and share. It'd be really appreciated and help get the message out. So fantastic hypnotherapists like Gary with so much to offer. So until the next time, be good to yourself, and we see you all on the next episode of the podcast. So take care, folks. All the best. See you soon. And bye.
Yeah.
And that's it.